As we all know, LASIK is an excellent refractive surgery that typically ends with very happy patients and great visual outcomes, but complications can arise. And some of these complications arise around the creation of the corneal flap. Some of the flap complications that we see are listed here. Again, as you've heard, dry eye, and infection, and epithelial ingrowth. The incidence of epithelial ingrowth is approximated to be 0.03% to 9.1%, and a risk factor, as we know, is LASIK retreatments. Infectious keratitis involving the LASIK flap is much less common than epithelial ingrowth. However, the results can be visually devastating if this happens. So when a corneal flap problem persists, debridement or amputation even of the flap might be considered a reasonable intervention. Flap amputation can be considered as a last option when alternative treatment options fail, and this is because the visual outcomes may be less than optimal. But we were wondering, what are the visual outcomes in patients that undergo flap amputations? So we performed a study looking at the long-term visual and structural outcomes of flap amputations after LASIK. We looked retrospectively at 8 eyes of 7 patients with a history of a post-LASIK flap amputation, and we looked at those performed at Bascom Palmer over this 15-year period between 1998 and 2013. And we looked at different metrics, the visual acuity, the indications for flap amputation, the corneal metrics such as topography, refraction, and so forth. So let's go over the results. 2 of the eyes that underwent LASIK flap amputation were secondary to recalcitrant epithelial ingrowth. The rest of the 6 eyes had LASIK flap amputation secondary to infections, either mycobacterium infections or acanthamoeba. So we'll go and show you some of those cases. This is patient 1. Patient with epithelial ingrowth who had had ocular trauma 6 years after LASIK. And here you can see the initial slit lamp exam where there was a relatively minor epithelial abrasion and small flap edge deviation. 1 week later, however, he came back with progressive epithelial ingrowth and an overlying flap melt. And so the flap was lifted, debrided, and sutured back into place. 1 month later, however, there was contracture of this flap with microstriae and associated irregular astigmatism. So the decision was made to amputate the flap. Mitomycin C was placed on the surface to prevent haze, and 3 years later, the uncorrected vision was 20/30 with the best corrected visual acuity of 20/25. Here's a second patient, a patient who had suction loss during their primary LASIK with a resultant temporal flap truncation, so an incomplete flap. And this patient presented 2 months later, complaining of glare and decreased vision. The slit lamp exam revealed epithelial cells underneath the remaining LASIK flap, causing temporal scarring and thinning. And here's an example of this patient, number 2, where you can see significant corneal scarring and epithelial ingrowth underneath the remaining flap. The patient was tried to be fitted with contact lenses, however was contact lens intolerant, underwent flap amputation due to the scarring and irregular astigmatism. And 1 year later, the patient's uncorrected and best corrected vision was 20/30. How about the cases of infectious keratitis? This is a patient who had acanthamoeba keratitis 10 years after their original LASIK and had significant decrease in their uncorrected visual acuity. And here's an example of a classic acanthamoeba keratitis. In this case, the patient had had prior LASIK. They've got a ring infiltrate, and These cases are notoriously difficult to treat, even in the absence of prior refractive surgery, but certainly where there's a flap involved, this flap can cause the absorption of the drug to the infected area to be diminished. So this patient was treated with topical amikacin and clarithromycin, and was treated with PHMB and neomycin hourly, and 7 days later the neomycin was dropped and chlorhexidine was added. However, the patient was not doing well and underwent flap amputation. Here we see the patient after the flap amputation, and 6 months later, the uncorrected vision was 20/40, best corrected vision 20/25. Here's a slit lamp picture where you can see a little bit of residual scar, but a good bright corneal reflex. Here's a case of 5 eyes. The rest of the 5 amputated flaps were from mycobacteria infections, different species as you can see here, with a mean uncorrected vision that was quite poor. Here is a slit lamp exam of the infection, persistent despite amikacin and clarithromycin. Here's after the flap amputation, and 6 years later, mean uncorrected vision of these 5 cases is 20/50. Here's an interesting topography. Although we had orb scan technology 10 years prior and the TOMI 10 years later, you can see that from 1 year after flap amputation to 10 years after flap amputation, there really was not a significant change in the refraction or corneal topography. It looks like there's a change, but that's just because of the imaging that was used. But in fact, if you look at the numbers, there was fair stability over this period of time. So in conclusion, we report 8 cases of flap amputation resulting from uncontrolled infectious keratitis or epithelial ingrowth after LASIK. And despite the very complicated course of these patients, all of them achieved reasonably good vision after flap amputation. Finally, the trend seen in these patients refractively is that they had hyperopic astigmatism or mixed astigmatism, which may be due to the epithelial changes, and secondary procedures like PTK or PRK can be used as an adjunct to improve the final visual outcome. Thank you very much for your attention.